Good afternoon, everybody. My name is Bob Gold. I am the chair of the Department of Epidemiology and Biostatistics here. Prior to that, I was the founding dean of the School of Public Health. It's a pleasure to see you all here, and I want to thank the current dean and the dean's office for providing support to join us in sponsoring this session this afternoon. We're really pleased to have Dr. Oscar Alleyne from NACCHO here. You'll hear a little bit more about him in a few moments. My task is simply to welcome you and then to get out of the way and let the good things happen. So let me introduce Dr. Tiffany Dyer, Assistant Professor in the Department of Epidemiology and Biostatistics, who will take care of the further introductions. Thank you very much.
Thank you so much. Welcome, everyone. Thanks so much for being here. Before I get started with introducing Dr. Alleyne, I want to ask if anyone has a seat. Besides me, I have 3 seats next to me. Who has a seat next to them? If you can just raise your hand. We have a couple of people who are standing, and we'd like to allow them to sit down if that's possible. And there are several seats in the front as well. So one of the reasons why we gathered here today is, even in terms of just introducing Dr. Alleyne, myself and another professor both teach Foundations of Epidemiology, and as many of you know, if you're epidemiologists or interested, students learn about foundations of epidemiology. So everything from causality to effect modification, confounding to surveillance and screening. So while those are prominent concepts in epidemiology, we thought it'd be a good idea to contextualize some of that and bring someone who was an expert and had hands-on experience in terms of how to apply some of what we learn in epidemiology in his daily life. And always in the background, even when we're thinking about some of those concepts, are emerging diseases, often emerging infectious diseases. 2 years ago, it was Ebola. So we had a lot of students who were interested in learning more about that. This year, it's Zika. And so we want to understand Zika from an epidemiologist perspective, and that's Dr. Alleyne here. Oscar Alleyne is Senior Advisor for Public Health Programs at the National Association of County and City Health Officials. He provides leadership and senior level management of a portfolio of $14 million. He covers the programmatic divisions of infectious disease, again, so that's a topic of interest for a lot of students and a lot of faculty here in the department, and informatics, which is actually Bob Gold's area of focus as well. Public health preparedness, pandemic and catastrophic preparedness, and environmental health as well. Dr. Alleyne began his career in governmental public health, designing software used as an expert system in guiding responses to adverse water quality events in New York. And he spent 15 years at the Rockland County Health Department in New York. During those 15 years, Dr. Alleyne served as Director of Epidemiology and Public Health Planning, responding to and mitigating several of the major health issues that we can think of over the past 15 years, if you're that old. West Nile, anthrax, smallpox, monkeypox, and Ebola, amongst many. So he has experience as a planning section chief for the disaster medical assistance team, and just a wealth of information and knowledge as it pertains to how to mitigate emerging infectious diseases. He holds a doctorate in public health from the New York Medical College School of Health Sciences and Practice, and is a graduate of the University of Albany School of Public Health. So without further ado, I'd like to introduce Dr. Oscar Alleyne, who is going to respond to Zika and give us an epidemiologist perspective. Thank you so much.
Good afternoon. And I'm very honored to be among you this afternoon to give you a few words from a public health perspective as it pertains to Zika and the landscape that we saw and continue to see ahead of us. As was mentioned, I will give you the caveat that you'll see a bunch of slides, but you'll hear a different story, specifically as it pertains to the field of epidemiology from the perspective of those who we call the applied epidemiologists. So oftentimes we find the theoretical, the research. There's a piece of us who are a piece of, folks who say, that's great, but it's the applied side that is of utmost importance as well. And I hope to impress on you, especially as the next generation of epidemiologists and of public health professionals in general, the value of that applied aspect to what we do. So the National Association of County City Health Officials is essentially the one member organization that represents the 2,800 health departments across this country. 2,800 health departments. That's not necessarily a small number, to say the least. Our whole focus is to address issues as it pertains to administration of applied public health with the lens of equity, excellence, participation, respect, integrity, leadership, science, and innovation. We kind of capsule our products, as we would say, or a consultancy model within the organization around these core fundamental areas: community health, environmental health, public health infrastructure and systems, and public health preparedness. But in reality, what NACCHO does, and notice I said NACCHO, not NACCHO, what NACCHO does is take that concept of the idea, whether or not it's something that's being done in the field or something that's been innovated around model practice or best practices, or that what we would say evidence-based practice, and then the other side that I would say practice-based evidence. Take that idea, illustrate its value through the discovery and evaluation component, show, test, pilot it, get some real-life in vivo results, develop it as a community of practice, and then disseminate it for national implementation. That's really the lens and the scope of which the organization operates, and we're kind of like a three-legged stool. What I just mentioned around innovation, support of local health departments, and getting their voices collectively at the national table to ensure that what's being done on the field has been exemplified and amplified in the national lens. I provide this slide somewhat as a tongue-in-cheek to give you an example. When we talk about the public health system, let's start with the federal system. Those of you who are into public health, especially here at the School of Public Health, should be familiar with what the federal healthcare system looks like. Department of Defense, Department of Health and Human Services, VA, Medicaid, CDC, mental health, HRSA, Indian Health Service, FDA. Those are kind of the great organizing centers under which public health is situated here in the United States of America. And this is just an example of what that then basically filters down to: a hodgepodge of various agencies, organizations, and anyone who in any shape or of respect, I would say, would probably term this as typical bureaucracy. Now, I show you this because we have to come back to something which I believe you all would be familiar with: the essential public health services. These 10 essential public health services are actually how people operate on a local perspective on a daily basis, from the monitoring of diseases, diagnosing, inform, educating, and empowering, mobilizing community partnerships, developing policies, enforcing laws, the regulatory arm which we serve, providing linkages to, providing care, assuring a competent workforce, evaluation, and while we're doing that, continue to assess, develop policy, and look at the systems through the evidence and the value of research. So, most public health departments across this country do a lot of things. We find that a majority of them are involved in communicable disease surveillance, adult immunization provision of services, childhood immunization, TB screening, environmental health surveillance, food service, TB treatment, food safety education, population-based nutrition, and daycare and early intervention, activities. So what does that look? Are we all the same? Remember I said there are 2,800 local health departments. So when you see one health department, you see one health department. In reality, those 2,800 health departments all have different flavors and styles to how they conduct their business. They also have different governance structure. Majority of the health departments are what we call locally based, meaning that they are, let's say, use the word home rule. I'll use the example of New York. There are 57 counties in New York, 62 if you count New York City. Each of those counties are responsible and have the onus of responsibility for the provision of services and care for the communities which they serve. In addition, there's a state health department system, which is broadly responsible for the entire health system. But the locally based system has as much power as that of the state-based system. So what you see here in the darker shaded capacity here, those counties where home rule exists, it's a county-driven entity that is the organizing entity. Then you find those that are mixed. Then you find those that are shared. Then you have those who don't have any such system at all. And usually you find that in the Vermont and the northern New England sections of our country. Now, This isn't just a attempt to make sure folks in the room don't have ADHD, but to illustrate through jelly beans what a local public health system looks like. Right there in the middle is the public health agency, the local health department. Surrounding that are these complex networks and systems of different organizations that they have to interface with in their daily provision of services as it pertains to public health. So schools, EMS, neighborhood organizations, civic groups, nursing homes, federally qualified healthcare centers, drug treatment centers, the clinicians, the hospitals, the doc in the boxes, as we say, elected officials. You never want to deal with them, but they're part of the problem. Fire, faith-based institutes. All of these aspects all play a role in how local health interfaces and the work that they do on a continual basis. Another thing, which isn't necessarily on this slide, especially as it pertains to epidemiology or the control of diseases, each local health department has the responsibility on a daily basis of addressing the national notifiable diseases. In some states, there are up to 70. Now, think about it. Daily, I, as an epidemiologist, had to monitor 70 diseases to ensure that we either or the physicians have adequately diagnosed or they've been properly reported and that we can prevent outbreaks from happening before they occur. But what we're noticing is that the global health risks are continuing to rise. And think about that for 1 second. Avian flu, HIV, food supply, multi-drug resistant TB, carbapenem-resistant enterobacter, it's anthrax. All of these things are illustrative of how quickly our world has gotten much smaller. And the impacts of things that happen on one side of the hemisphere impacts us here in our daily lives. Another interesting thing that I think is very important to provide as a juxtaposition, when addressing the causes of death that we see, we have actually seen a major shift over the course of the last 50 plus years. You think about it, most of the diseases that were killing people were infectious diseases. So that's why we had so much money being put in to infrastructure around dengue or mosquito control or TB control, because they were spread person to person. We've seen the shift now, instead of the leading causes of death being that of infectious diseases, into the chronic conditions. Now, what does that mean? Am I saying that you're ruining yourself by going to a career of infectious disease epidemiology? Not at all. Because the chronic conditions in of themselves impact everything else along that spectrum of health. And recognizing that how we invest our resources and our training and our understanding around these parameters is important if we're ever to really make a dent in improving the health of our communities. Which brings us to Zika. You probably have seen this, so forgive me if it becomes a little bit pedantic, but it's a single-stranded RNA virus. Here's the genus, here's the family. It's related to several other diseases that we've seen that are also spread by mosquitoes: dengue, yellow fever, Japanese encephalitis, and West Nile virus. And it's primarily transmitted by a bite of an infected mosquito. The mosquito of our concern is Aedes aegypti or Aedes albopictus. And they're nice little pre-examples of both of them. Now, Zika has been around for a while, ironically enough. Before 2015, most of the outbreaks were in Africa, Southeast Asia, and the Pacific Islands. And we also recognize that currently, as we know in the point of today's talk, that it's been impacting several countries and territories at this time. The mode of transmission, you get bitten by an infected mosquito, or maternal-fetal interaction, where you have a pregnant woman who passes on the virus to her unborn child. There's also one of the more unique aspects of this particular virus is the sexual transmission that occurs between an infected person and his or her partners. There could be laboratory exposure, and we've also seen the probability is high around blood transfusion and organ and tissue transmission as well. Now, looking back through the lens, so I'm actually going to walk you through a real-time time-space differential. The infection rate is high with respect to, when I say high, 73%. That has been shown from prior exposures and outbreaks back before it came to continental US. Specifically, these are, using the CDC slides, these are based on an outbreak that happened in 2007 in Yap Island. Symptomatic attack rate was about 19%, which meant 90% of the individuals who had illness showed symptoms. That tells you a lot more didn't illustrate symptoms. All age groups are affected, and while adults are more likely to present for medical care, they weren't able in the Yap Island 2007 outbreak to illustrate that it had a preponderance of death and destruction. But we know the incubation period is anywhere from 3 to 14 days. It's typical for any mosquito-borne illness. We know that the viremia, how long you present with this illness, can range from a few days to a week. And we've seen evidence that pregnant women can have evidence of Zika in their blood much longer than this time frame, and that the virus remains active in semen and urine much longer than in blood and for an extended period of time. Clinical symptoms is any particular issue, and I would say this from my years as being an infectious disease epidemiologist, or basically a master of all trades. Everything presents as the flu, right? Think about it. Malaise, backache, low-grade fever, maybe some headache, maybe some photosensitivity. That could be anything. Actually, that's everything. So, as we joke, oh, you must have Zika, someone coughs or sneezes, the reality is it could be possible. But the fact of the matter is, when we look at these types of illnesses that affect us almost all the time, it's the same type of clinical presentation that causes one to either deal with concerns of how to address the word well versus those who are adequately or significantly sick. While fatalities have been rare, we have seen another aspect of within this disease that affects us the most, that of the neurological and the negative birth outcomes. Guillain-Barré is another syndrome that's been shown to be highly associated with Zika, and, as I said, we're going to get to the issues of microcephaly. Now, as I just illustrated how people can become sick and show symptoms, we also recognize that there are people who would never show signs and symptoms whatsoever, and that confounds a particular problem. Moving through quickly, how then are you going to be able to know if an individual has Zika, right? You test. So here's the problem. Prior to much of the evidence that's been done through the CDC in provision of laboratory and FDA for differential diagnosis, there really wasn't a test that you can provide for Zika. Why? Cross-reactivity with other diseases that we know to exist. So if you're positive for Zika, you're positive for dengue, yellow fever, West Nile. So how the heck do you know? There wasn't necessarily a test or a clinical, a testing procedure or methodology to identify specifically Zika out of a list of all these other diseases that can have what we call cross-reactivity. So diagnostic testing had to really be developed. They ramped up efforts, and CDC tried to essentially license a number of state labs to be able to provide this diagnostic testing in preparation and response to the growing need for testing of individuals who were presenting or who felt, hey, I just came from an area. You guys saying Zika, I was in Brazil, Central South America, what gives? So the recommendations for Zika testing was quite interesting. And I'm going to walk you through this because there's going to be a component where you're going to see me shift into the public health realm. All pregnant women should be tested. How are you going to accomplish that? Do you mean all pregnant women run to the doctor's office? Right? So every doctor, you should be prepared to provide the test for Zika for any woman who's pregnant. Now, we all know access to health care isn't that great to begin with. The advent of the ACA has actually provided us with some improved coverage rates for individuals who need health care, but it's not a fundamental fact that we know everyone out there has access to particular health, especially prenatal or perinatal care. So who does that responsibility fall on? The local health department. Because they have become essentially what we call the safety net of services when no other services are available. And that's part of that rubber meets the road scenario that I wanted to address. So these recommendations came out, these kinds of discussions were being put forth, and the fundamental issue that was always coming to the table, well, how are we going to do this? Who is going to help us understand it? Who's going to digest the information that we're getting from the federal departments of health? The local health department. Because you're not going to pick up the phone and call the CDC. You're not going to pick up the phone and call the state health department. You're going to go to the one place that you think that should be able to have that answer and you have access to. And here is where some of the fundamental concerns has always been as it pertains to how we in the public health world respond to these types of threats. We need situational awareness. When we don't have situational awareness, it's very difficult to provide the folks that you serve with the answers that you need. I'm jumping ahead, but we'll get to it. So the idea came about that there should be the development of a Zika pregnancy registry. Well, that's nice because it allows us to focus on those who are at most risk, right? The pregnant women. Because it is a mosquito-borne illness, doesn't necessarily mean that you're going to die from it, but the one thing that we're most worried about are our pregnant women. So how do we track our pregnant women and not only identify who may have been exposed to Zika and what impact it has had on the outcome of their birth? So we know that if you are exposed to Zika in any aspect or any part of your trimester, first, middle, or third, you are at risk still for having a negative birth outcome. So the development of this U.S. Zika pregnancy registry was put forth. And one salient point that I think is important to note, these things are generated from that state perspective. The federal groups are going to say, we're just going to talk to the states because the states are the ones that are supposed to manage these systems because they're not going to work on 2,800 different systems. So there must be one centralized system. But the people who enter the information about the pregnant women are not operating at the state level, they're operating at the local level. So how do you provide the resources necessary to train them, to provide them with that kind of risk communication needs to say, here's how you identify pregnant women who are at risk, here's how you interface with their provider to ensure that they're reporting to you this information, and here is how you ensure that they have some kind of calmness of self or feeling a little bit less stress as it pertains to what happens now that they've been identified as someone who is at risk for a negative birth outcome. Some of this I'm just going to slide through. It's for the purposes of illustrating to you. These clinical guidance came around as to how to approach pregnant women. Now, it's nice if you're clinician to see this. It's simple. You can follow any kind of matrix or fabric or rubric. Here's a problem. You're not dealing with an issue that's just A to B to C. You're dealing with human emotions. That's public health. How to translate the science, how to translate these type of processes into things that are healthy decisions, stressful decisions, and things that impact people's lives. And that, I would tell you as an epidemiologist, is one of the most difficult things you will have to face in how to translate your scientific knowledge into things that connect with the human aspect of the world in which we serve. So, recognizing that congenital Zika syndrome exists and how to talk to people about that, how to be ramped up with the other aspect of the public health team, the maternal and child health professionals, the health promotion, the community health workers, to get everyone on that same page so that they can educate the communities that are anxious because they go on Facebook, they go on Twitter, they go online, they go on YouTube and see everything. The world is falling, the sky's falling because Zika is here, we're all going to die. How do you combat that particular type of activity? Microencephaly. I actually use, and there's a latter slide, but it's important for you to at least understand the whole congenital microencephaly issue for live birth. Basically, and sorry to put it in these terms, you have a baby with a smaller head circumference. That means a lot because while we focus on the pregnant women and their exposure to Zika and those negative birth outcome, now you have someone, a child, an infant, who now has to progress through their entire lifespan needing support and services. So the responsibility is not on the clinician to provide those services. The responsibility is not on the state or on the federal agency. The responsibility is on that health department to ensure that there's a connective point with that individual to ensure that that family or a series of families are followed through the course of time, that there's access to the services, whether or not it's early intervention, childhood development, all the maternal and child health baby indicators to toddler, to to teenager, adolescents, adult. That's the lifespan. That's the impact this disease has. It's not just 10 days you're feeling better, you're done. Yes, you're an adult, that may be the case. But from that baby with a negative birth outcome, you're talking a lifespan now that requires assistance and requires focus. So I would tell you that, to be honest, when I sat in rooms with the Centers for Disease Control and we spoke about, well, what do we do about the sexual transmission? Because it's important to know one thing. The first indication and identification of a sexually based transmission of Zika was identified by a local health department in Texas. And I'm going to tell you a story how that occurred without necessarily revealing information that could get me in trouble. Health department had someone who came down with symptoms. They felt we should get that person tested. So they approached what would any normal health department do. They work within the team perspective with their state counterparts to say, hey, we have this person present with signs and symptoms. They haven't really left the country, but is very kind of fits that kind of matrix. So can we get them tested? Well, why? What are the other risk factors that would make them eligible for testing? Well, they had a partner who just came from an area that had Zika-related activity. Yeah, but we're not necessarily sure that's the case. This hasn't been proven. It's been suspected, not proven. Okay, we want to test them. No, we're not going to test them. Now, the difficult part now as a health department is how do you jump over your state counterparts to get to the federal counterparts? So that's where we come in, right? We come in and we're like, okay, what's going on? We'll tell you what's going on. We want to test this person, and we can't get tested. And, how do we facilitate that? Okay, let's figure things out. Then it comes out that, okay, they pressured them enough, got the test done. Then we got a call. They got a call back saying, well, we want to talk to you about that individual, but we can't tell you why. What do you mean? Well, we need you to go back and collect more specimens from them and their partner. Do you have the results of the test? Yeah, we can't tell you. What do you mean you can't tell us? Yeah, we don't want to tell you. So that now comes in that contentious interaction, right? Because what do you mean? We're a team. We're public health. We should be working together. But for the purpose of that conversation, it really had to be one of those knock 'em out fights where the reality had to come up. Like there was a suspicion that they were right all along, but sometimes you can't tell other people they're right, especially when they're local health departments because they're not supposed to know anything. And the reality was exactly as they thought. It could be spread sexually. Now, ironically, one of the reasons why I would say it wasn't necessarily pushed heavily was because of the type of the sexual interaction that occurred. It was a male-to-male interaction. So of course, you say there are concerns about whether or not individuals may be identified and et cetera, but that in of itself was an issue because the message was about pregnant women. And of course, the negative public perception. If you say this, well, we can just make broad-based comments that could be necessarily incendiary. But the reality from a risk communication standpoint, we realize that everyone needs to be concerned about this. Not just women who are looking to become pregnant or can become pregnant. And then more cases started happening. More cases for people who never left this country. And the length of time started to increase. So it wasn't within the last 2 weeks, to the point where the messaging that now we as a health community need to know and figure out how to address this. How do you tell people that refrain from all aspects of sex? And if you're looking to become pregnant, don't have sex, unprotected sex, for at least 6-7 weeks. Yeah, that's not going to fly. The one thing I can say when I sat in the room, which was actually quite interesting, one of our other issues, let's take Zika off the table for one quick second. One of the issues that we have to contend with is the high rates of STIs, sexual transmitted infections, in adolescent, young adults, adult population, and older adults. It's the entire spectrum. And STI has become such a crescendo that I sat there and they're like, well, as we went to the Zika summit, well, what can we do? It's like, well, let's make Zika condoms. Think about it. And I'm sorry if I seem to be a little bit over the top here. Say, honey, I love you, but Zika. Everyone gets that, except when I sat in the CDC, they said, I don't think we can do that, Oscar. Like, 2 birds with 1 stone. We knock down the STIs and you protect Zika. No? Okay, I'll market mine to Trojans and see if I make money off of it. So we know that Zika exists in seminal and sexual and bodily fluids, and it has a long-lasting range, and it tells us one important aspect about, and what I'm showing you here as I flip through many of the different kind of messaging around the types of people, the types of couples, the type of issues that you want to address through risk communications. But the point of the matter is, it showed that this virus, we didn't have all the information about. And that's another aspect of public health that is very difficult to address as you're in the midst of something. Ebola, H1N1, monkeypox, smallpox, you name it. When things are moving in such a rapid pace and things get changed or you have to make a pivot, the reality is public health has the task of knowing how to adapt, be nimble, and be flexible to respond with a surety, in some respects, around what they know. The problem is when we don't articulate what we don't know. And we get the conspiracy theorists, the general public, the people who feel that, you guys are just, creating the stuff here. And I'll tell you another story about that. One of the first messages we saw on social media that when Zika was coming in Brazil and, it's coming to America, that it was spread by genetically modified mosquitoes. And that wasn't the case, but people believed it. People believe whatever they want to believe. I mean, all you have to do is get a PhD from the University of Google, and an MPH from the School of Public Health of YouTube, and you're good. So one of the things that we had to do in addressing that particular scenario was, we had to say, no, that's not the case. This is not the etiology. This is not the source. And then months later, we hear we have an idea, and the FDA is looking to implement a strategy that would be kind of unique. We want to introduce genetically modified mosquitoes, which will essentially knock down the Aedes aegyptus albopictus mosquito. And I was going to say someone, but I'll admit I said it. I said, well, we just got through telling people that GMO mosquitoes and this whole genetically modified, gargantuan mosquitoes are not the cause of Zika. And you want to introduce it? I mean, just think about risk communication, no? And of course, the public perception and the pushback kind of put that back on the back burner. But it just illustrates the need to be connected. As I said, some of these things I wanted to fly through for the sake of time. But this is important from a number of lenses. As an emergent public health emergency, adequate preparedness for Zika has proven difficult due to the challenges that we know exist. These challenges are resource limitations, funding, personnel, competing priorities and ongoing activities. Other diseases, whether or not they're communicable or non-communicable, don't sit by and just wait and say, all right, we'll wait for you to get done, get your attention with Zika, we'll sit in the corner. No, they progress. In fact, sometimes they get jealous and amplify and say, look at me. So how do you address these competing priorities as a public health professional, as a system that needs to be flexible in their response? Rapid evolution of information and knowledge, unfamiliar vector. One of the things that we recognize with Aedes aegypti and albopictus, I kind of mix them together into like Voltron, is that it's a totally different mosquito than what we have been accustomed to in the last 15 years of vector control activity. I came in at the beginning of West Nile virus in 2000. My county became the second epicenter of West Nile activity after New York City. And we were just about 40 minutes north of New York City. It came to the point that any mosquito, any bird, anything we sent to the state lab, they wouldn't even bother test because they said it's going to come back positive. And it did. Everything we submitted was positive. So we had ramped up our activities. We provide training. We brought in AmeriCorps volunteers. We trained people on how to go do source reduction, how to recognize that if you have a bottle cap with a little bit of water, that is enough to spurn mosquitoes. You need to be worried about that. We did overhead flights where we looked at everyone that had an above ground pool, and we're able to map those out and send letters saying, hey, if your pool is green, it's a little mean, so you need to do something about it, right? If your pool is blue, then fine on you. We did the whole fight to bite, all these things to get things into play. And Aedes aegypti and Aedes albopictus don't operate like Culex. For every one bite you may get of a Culex pipiens mosquito, the Aedes mosquito bites you 4 to 5 times. It's aggressive. There's a reason why the Centers for Disease Control director, Dr. Tom Frieden, has called it the cockroach of mosquitoes. It lives closer to its human habitat. The others would be out into open water breeding sites, ledges, all this type of trees, etc. No, Aedes wants to hang out where the action is. So how you treat it, how you identify it, is much different. The tools that we use in the field, so let's say we set up a gravit trap, which is essentially a murky water contraption that allows the mosquito to come in, lay its eggs, and get trapped. It doesn't respond to that. It doesn't work. The light traps where you emit carbon dioxide and other things to make it mimic, the type of things that would attract a mosquito, and it gets sucked up, so now we know what a mosquito. Now, cockroaches don't fall for fancy devices. And I'm using that kind of term in the sense that now you're looking at a public health system that has been reduced to its challenge around how to fund an infrastructure to now have to invest new resources to attract and deal with an issue that it never had before. So how do you overcome these challenges? Here's what happened. Funding, as I just showed you, the federal, state, and local level, operates in that fashion. It starts up here and goes down. So when you look at monies that are available for you to provide services, federal agencies are where you get the dollars gets granted to the states, and the states make their determination as to how much of it they're going to pass down to locals. Now, this picture is a look at the vector control services that are being conducted at the local level, specifically at the local health department. You're recognizing that the map isn't entirely one color. So there are significant gaps in this patchwork of provision of services to address mosquitoes. So how the heck are we going to fight against a mosquito like Aedes? Now, over the course of time, this is where we've seen the Aedes mosquito. So that tells you that maybe we should focus our energies on places where mosquito-borne activity is quite pronounced. But here's the problem. When you look at when, in February, where the diseases started happening, they were not only in that lower quadrant, they were all over. So the likelihood is there may be the chance that a mosquito can bite an infected human and you see the locally based transmission, because that turns to the whole biology and etiology of the disease. So by March of this year, we saw further extension as to the spread of illness through travel-related illnesses, as well as the concern, as we see later in Florida, with the homegrown scenario. So in May, something else hit us, and you guys probably had no clue that it existed. They took $44 million out of a budget that would have gone to local health departments and states for emergency preparedness. Why is that a big deal? When you take $44 million out of a thinned population, you have some negative impacts. 75% of community preparedness activities were at threat. 47.5% of volunteer management. Medical countermeasure dispensing, emergency operations, community, the ability for folks to be ready, for them to have, these are the impacts that they saw from that money not even coming back to the health departments. That money was essentially redirected to go to the CDC so that the CDC can fight Zika. There was no promise of that money being sent back to the locals at all. So essentially, you're robbing Peter to pay Paul. But you're robbing Peter in a way that impacts how he has to respond to Paul as well. Because if you don't have the community preparedness activity or the operational foundational capability to respond to anthrax, you're not going to have it for Zika. And you hope the trickle-down theory works that, okay, well, the CDC got money, they can keep their lights on, what about us? So the reality is, these are some of the issues that impacted us and why we kind of galvanized our efforts to speak out about the concerns about these FEP cuts, and more specifically, our support for the call that the president made to supply $1.1 billion to help us fight Zika. Because it makes sense to fight it now versus later when we have a preponderance of cases and individuals who have negative birth outcomes who are now parts of our community society. And we see that the impacts that these cuts have, about 50% of our local health departments who have done, despite the fact that having money, we become altruistic. You got to do it somehow. So they still were doing these activities to help in such way prevent the course of illness that could hit our paths. And we just have an infographics that we tried to scare the congressional folks. It didn't work because they went on vacation. They didn't care. In fact, one of the things I said at one of our summits was, maybe what we need to do is just cart out, because you think about it. If there's things that affect veterans, what happened? The veterans are out there. If it's something that impacts the disabled community, you roll people out of wheelchairs. And as macabre as it sounds, maybe we need to start rolling out people that have babies with small heads. Maybe that's what's going to take for people to realize, instead of making it a partisan issue, where we'll give you money, but we want to take money away from Planned Parenthood. When we recognize that the issue impacts contraceptives as well. So how do you, anyway, I'm sorry. This is where you get me in trouble. So I'll give you an illustration of what local health departments have done in action across the country, recognizing that, yes, they've been cut. They leapt into whirlwind of activity. They launched public health campaigns. They did the Zika Fight to Bite survival kits. They addressed issues like Los Angeles, where they developed surveillance strategies, forums, trying to get their local vector control agencies to advise them how to address the new form of this mosquito and what to do. North Carolina, they started doing surveys in communities to assess the impact of the mosquito conditions and take samples. Douglas County in Nebraska, worked on setting up traps back in June. All of this while still waiting for money to trickle down. We also recognized that the laboratory capacity was an issue. So they reviewed how to do specimen testing, how to essentially address pregnant women and their symptoms, and the large number of people who were coming in from travel-related illnesses. What we can do around strategies around awareness and focus on pushing back at the congressional level and the federal level to say, hey, let's get our act together. Then June hits. Who follows soccer here? Anyone heard about Copa? Let me tell you about Copa. It's a soccer competition that existed for the month of June. It covered 10 cities, featuring teams from 16 different countries for 32 matches. The first time in its 100-year history it has ever been in the United States. 16 cities. 12 out of those particular countries were Zika-affected countries. So you had an estimated, I think they said, 2 million expected as far as participants and spectators to be traveling all over following their favorite teams. What do you think about? If people come from Zika-affected countries in the midst of June, we're worried about Zika, what's the likelihood of, let's say, someone coming symptomatic, and how do we have a health system that's responsible enough to address it if they present at a hospital? And also, what is the likelihood of probability of, I don't know, maybe transmission occurring from that local perspective? So the coordination efforts, someone finally said, well, maybe we should talk to the local health departments. I said, yeah. So I called a couple local health departments. I said, hey, you had that stadium there in San Diego, right? Yeah. There's a soccer competition with about all these folks coming? No? So coordination and situation awareness is important. And we were able to at least rapidly address through preparedness activities and dealing with state as well as local cities, how they would be integrated, how they would identify the communication between the U.S. Soccer Federation and the medical directors in each of these particular teams and activities in a way that allows, if you do it from the prevention aspect, you don't have to do it from the reaction. So moving through July, just my organization alone, we had spent about 575 hours dedicated to Zika. We've developed blogs. We had 17 staff on it, and that's just the national organization. The local health department's done way more than that. So what came next? The development, and you guys don't see this, but there's a development of plans and exercises and capabilities that hopefully folks can follow. So there's guidance for schools, there's vector control, like the question was, well, what does our vector control look like in this country? I'll tell you, not a lot of people know. birth defects, Zika surveillance, Medicaid, develop applications in such a way that's supposed to provide for those who are Medicaid eligible to receive some benefits of intervention and prevention strategies for Zika, and community engagement. This is a snapshot as of the 21st of the number of cases that we've seen laboratory confirmed across this country, including the territories. This is a snapshot using the maps and everything else of what happened in Florida. Why? Because Florida became ground zero. They were part of what we said were the priority jurisdictions, and between Wynwood and then, of course, Miami-Dade County, they started to get cases that were not associated with foreign or travel at all, or transmission that were related directly to an individual travel, but was local and homegrown. And that was the point at which everyone started to say, we now have to step the game up because it's here. There's thousands of cases. I think we've had over the course of time, 3,000 travel-related cases, total number of sexual transmitted 28. The locally acquired cases in the territories inclusive is over 19,000. So the idea is that, of course, the disease is around. What can we do? So how to address now the public perception? Because what I got as a senior advisor and as an epidemiologist is like, oh my God, Zika's in Florida. I can't go to Florida. You can't go to the particular, no, I'm not going to, look. Or I have people who, she'd be embarrassed who sees this, like my mom. It's like, well, mosquitoes bite me. And I said, well, I have something I have to say to you. If you're planning to become pregnant, you and I have to have a much longer conversation. At which point she said, get off the phone. I'm going to call your aunt and tell her what she said. Vector control competency is something of very significant interest to us. Because when you look at where the mosquito of concern is and the patchwork of programs and services that are supposed to provide a response to mosquito control, it's not a full coverage. Vector control isn't handled by state health departments, and it isn't handled by federal health departments. It's actually a very locally derived activity. So you either have the health department that does it, or a municipality that may have a mosquito control district, or a parks and recreation, or transportation division, or a village, or a local kind of municipal type of setting. So how do you quantify that? Within the jurisdictions that, let's say, we have some concern about, there are over about 300 of these entities that existed. They are not at the same level of competence. So while some may do larvicidin, others do adulticidin. While some may utilize human surveillance information that is gathered by the epidemiologist in a particular health department, others just go based on complaints. Others may not necessarily do things such as pesticide resistance testing, meaning after you've applied pesticide, have you now gone to provide a system to see that what impact it has on the mosquito, and has the mosquito of interest started to change its resistance to the type of pesticide being applied. All of these are factors that most people don't think about. But they kind of generated a fabric of sorts of how to determine where we are in this fabric of response to enable us to say where we need to move to. Where are we in the continuum of response to Zika as it pertains to vector control? Zika is not only an environmental health concern, it is not only a maternal child health concern, and it's not only an epidemiological health concern. All of these aspects in the framework of public health need to come together to address these particular issues. But what it is are we doing? Now I turn the page to you. As epidemiologists, either young, middle, or early career, or moving forward, what is it that we're really supposed to be doing? What is our charge, our mission? Who are we intended to inform, influence, and persuade with our craft? What purpose is EPI with the intent of what it's trying to accomplish? Whose needs are to be met? As you go into the field and look into the lessons that you're learning, what questions need to be asked, right? We love asking questions. And what do you do when you already know the answers? And what can you do to change the situation? How will epidemiology adequately be used to advance the prevention strategies and the agenda necessary for us to protect the health of our communities? And what timeline exists? So flipping that coin, I kind of used this phrase when I presented to the Congress of Epidemiology a few years ago, in the summer. Today, the need for leadership is too important to leave its emergence to chance. We can't go around waiting for someone to decide that, okay, we'll give you money. And this is back in 1988. Some of you were born right around that time. We won't continue. But from a public health perspective, here's what's happening out on the ground level. We're losing senior leaders. People are retiring. With that, we're losing institutional knowledge. And there are differences in this generational leadership that exists in the new public health world and the old public health world. The next generation, meaning you and those who are coming behind you, whether or not undergraduate or graduate, et cetera, you need excellent educational preparation because there's no benefit for you to come into the applied public health world with limited training and support for the essential skills necessary for you to survive and for the public to thrive. And this need for that necessary transition element to work. So what do we do well, whether or not it's the public health schools or the public health departments? We do community health assessments great. We do database design. We do policy development. We translate. We interpret data. We synthesize data for policy recommendations. Infectious and non-infectious disease, we got that. We got that, close. Community level evaluation, we do good. Creating EPI reports for electronic health records, yeah, we're awesome. Look at us, we're EPI. Program evaluation, performance management systems, these are all things that we are being trained, and we could say we can do it with our eyes closed. But what do we do horribly? Leadership and management skills. Writing. There's a problem if we can't write at a level that everyone can understand. Media relations. As an epidemiologist, I will tell you, one of the first things that they were happy to do at the local level was throw me in front of the camera. And if I didn't know how to smile when I was asked a dumb question, I was in trouble. So media relations is very important for you to learn how to address media concerns, how to answer questions, how to not give your opinion when your opinion isn't asked for, and therefore you have a legislator or someone else saying, who the heck is that guy and why do we put him in front of the camera? Project management. Our schools of public health need to provide a lot more training and expertise in how you are learning to manage projects and people management. Just because you come out of a field or a school with an MPH doesn't mean you know how to manage people. You know how to manage data, but the management of people, those principles that oftentimes you may learn in business schools, et cetera, are fundamental for us to be able to address this changing dynamic in the public health world and how to tackle legislative issues. This is an issue I would say is probably, if you want to say the epidemiologist is the activist, is very important because people come to us for data, for validation, for information. And sometimes you find epidemiologists, or especially those in the research world, would say, you know, we're academic, we just do research, we don't want to have anything to deal with that. What you guys do out there, that's your bailiwick. But we have a fundamental responsibility and a social responsibility to ensure that the information that we gather, the reports that we prepare, the use of technology and the conclusions drawn are for the benefit of humanity, the benefit of the communities we serve, than to have a laissez-faire attitude that it doesn't matter to us. Because at the substrate, this is the other aspect that I know you're all familiar with, and I hope. The social determinants of health teaches us that you have the individual. The individual is influenced by all the factors that impact that individual, their lifestyle, but they're also influenced by their social circles, their communities, their families. But around that, their living conditions, there are these other factors that have an impact on what you do. So if I want you to stop smoking, I give you a patch, say nicotine patch, hey, stop smoking. You go home, your entire family's smoking. Nicotine patch is basically invalidated. Okay, let's say your family stops smoking. You're in a community where you walk into a store and the first thing you see are smoking ads. Or there are others around that community where it is, commonplace. The ability for you to now be influenced by those influences are quite diminished. Now take it a step back to things that we don't control. But there are policies, there are legislative practices, there are empowerment zones, construction, all these things that are in place that, from a policy perspective, filter down to the individual. And if we don't start to operate within the space of equity in everything that we do, we're truly not accomplishing the value and mission of public health. It's not the absence of disease. It's not. Especially when we look at Zika. It isn't the absence of microencephaly. It's what we are doing on a day-to-day basis to address the health and protect the health of those whom we serve. Thank you.
Thank you very much, Dr. Alleyne. Right now, we are going to open it up if anyone has any questions for Dr. Alleyne. Sure.
First of all, thank you for coming to talk to us. I was wondering about the conspiracy theorists. You mentioned the GMO mosquitoes. I've also read about an Argentine group that talked about pesticides in the water causing microencephaly. How do you deal with combating that misinformation?
It's one of the things I would say confounds us in public health. How quickly people can get information and amplify bad information. So I know the question comes in with respect to the use of pesticide. The question was that, well, in Brazil, it was shown that the one particular thesis is that the application of certain pesticides is actually what caused the microencephaly and not that of the Zika mosquito. Now, what hasn't been said in that particular conversation was the sample size that was taken, or the understanding as to what the mosquito control and the pesticide use is within that country, which is not a small country, and how those conclusions were drawn. From a scientific perspective, one could say that it was an inconclusive study. But we can't start drafting language against a particular study when it's already been caught and been amplified that this particular study says, and scientists say. So you compare now to, well, let's look at real-world statistics. If that's the cause of microencephaly in this particular country, what's the cause of microencephaly in these other countries who don't utilize that same pesticide? Causation versus correlation. But for me to stand up to express an objection or a viewpoint is a little bit difficult when the message has already gotten out. And you're behind the message, constantly chasing behind it, essentially, to dispel myths and dispel bad information. Part of that, I also say, has been the fault of public health. And whether or not it's due to the resources or the lack of resources to dedicate time. And I mean, we see some great commercials. God knows it makes us want to go buy things. But we don't have the same degree of passion and utilization and deployment of resources for public health messages. Why? Because they're not sexy. It's not sexy to talk to people about losing weight or eating healthier, et cetera. No, it's not. So the lack of resources to truly dedicate that, the inability to get in front of the message, and as well as we do things so well from a public health perspective when things are good, no one knows you're there. Most people think of the local health department in two streams. Restaurants. I went to a restaurant, I got sick. What are you guys doing? You're not protecting us. Diseases. All the other facets that I talked about, those 10 essential public health services, are happening on a daily basis. Their engines running, their trains going through, people are keeping things together. But no one talks about it. We don't stand up and say, hey, look at us, this is what we do. No. We continue to plug and play, keep our heads down. This is what we do. This is our goal. Shifting that kind of paradigm to say, we need to do a better job at publishing the work that we do, illustrating the value of what we bring to the table, and showing why investment in public health is important for protection of the overall well-being of our communities. And that's part of the issues that I can say are extant in why the conspiracy theorists get in front of things and we are always playing catch-up, or we have to ignore it because there are other competing priorities that we have to focus on. And we don't have the money that we could throw at the window as we wish we would. Thank you. Yes.
Hi, my name is Michael. Thank you for speaking with us. My question is, what is the interaction like with the public health community and doctors who are in their communities? Because are they a resource since they sort of know their community? So is there like that type of interaction, or are they just their own thing?
It depends on who you talk to. It depends on the geography which you're concerned about. Clinicians oftentimes are focused on their practice, their individual, their patient. And this is one of the things when I have to explain to people what I did as an epidemiologist. First, I have to tell them I'm not a dermatologist. You need to see a dermatologist for that. Pull your pants up. Secondarily, I have to express that, well, you know, those diseases that I talked about, the 70, 80 diseases on a regular basis, clinicians would have to report that to me at a local health department level. So you as a physician, you're dealing with your one patient, your two patients, three patients. I, as an epidemiologist, I have to look at the entire community. So at times when you focus on your patient and say, well, this person came in with the sniffles, et cetera, I just treated them with broad-based antibiotics and that's it, without knowledge that there's a staph infection happening in the community and what just happened with that patient is actually linked to all these other folks. And if you reported what you thought to me and we have that dialogue, that communication, then we could have a better strategy to ensure that we can stop it before it spreads. So in some scenarios you find in some communities, there's a great interaction between the clinician and also other parts of the healthcare coalition. So you may have meetings, you may have discussions, you may have physicians, federal qualified healthcare centers, physician assistants, nurse practitioners, the entire spectrum of health. You get them engaged to ensure that there is that better relationship building, that coalition, that sharing of information, that team spirit, if you really truly want to be successful. Working in silos does not help anybody. So in some scenarios, it has worked and has worked well. Other scenarios, there's still room for improvement. But everyone has a role to play. So for my example, I will send information to the school nurses almost on a weekly basis. I would address school absenteeism to say, how many of your kids are out sick? Or how many kids did you send home because of illness? And that allowed them to be engaged in activity with the local health department. So when someone came and said, which is one of the things of bane of our existence, oh yeah, my kid has meningitis. Here's the problem. There's bacterial meningitis, there's viral meningitis. Bacterial meningitis, not so good. Viral meningitis, sorry, it happens. But when you hear the term meningitis from a school perspective, school wants to shut everybody down, send everyone home, and not even question or verify. But by me having that interaction with the school nurse, it allowed them to say, hold on, let me speak to the epidemiologist. He and I are cool. I'll find out what I need to find out and have the ability to bring things down and respond in a way that allows either the clinician to know that if you're going to tell someone you have viral meningitis, tell them what type. Explain to them the reality so they don't have cascading effects that have an impact on the overall health system. Yes, ma'am.
So to frame my question, I work with the federal government and I get, different news feeds about progress on Zika vaccines, and you hear on the radio, you hear Dr. Fauci talking about different clinical studies. And so I guess I'm just wondering what your perspective is on the importance of long-term prevention, the development of vaccines and funding that versus working in the communities to prevent Zika right now. And because it's kind of a lose the battle, win the war situation, but they're people's lives. So
the best answer to the question, it isn't an either or, but an and. The problem is everyone's competing for the same resources. So you have to go to the federal government to hope that they'll provide money and dedicate funds to address this particular issue, while they haven't necessarily, from a congressional standpoint, provided that support. So the and gets into an either or. You can't get into an either or because no one wins. We need vaccines. We need vaccine development. Fauci's comments were very succinct when he went to the National Press Corps. We said that, okay, we've done phase 1. But in order to get to phase 2, we need the investment of money right at this point. If we don't have that, then everything we've just done is gone. Additionally, public health is saying, yes, we also need the resources to vector for maternal child health, for all these things, contraceptive care, all of the facets that tied into the reality around vaccines, because you need people in order to vaccinate them, right? So the either or doesn't really help any of us, other than the fact that we're stuck dealing with the same type of issues around funding and the provision of funding to support. And I think one of the comments was just made recently. If there was a war, people would have been, yes, you got the money, you got the green light, go. But they're not looking at it as a war on health or war on our lives. They're looking at us as a mosquito. Winter's coming, they're done. Like someone said to me, winter's coming. I said, yeah, that's cool if you're Game of Thrones. But this is Zika. Zika doesn't play that. So these are aspects that I think are very important for us to enunciate, communicate, and work collaboratively. So when March of Dimes meets with the NACCHO, meets with the National Association of Health official, meets with the ACOG, which does, and also the American Academy of Pediatrics, the National Native American Indian Health Services Board, all of us have a stake in the game, because we are all representing different aspects of communities, different aspects of the public health system, that a unified voice helps bring the message out that we all benefit collaboratively if we fight for the same common goal. Because the reality is, if not, we're all going to just fail. Yes, ma'am.
So how do we tackle these legislative issues and tell them that this is a war? We need the resources.
This is where your collective voice is important. This is where the activity of getting those people who vote to say, stop the BS, let's make things happen. And that's the reality. We do it as well as we can. We have advocacy toolkits, we have all these things, but there's a certain aspect that we can't go further. We can't go past. We know that there are folks that are friendly towards addressing these particular issues, and I just got an email stating that they're this close to making a deal. I don't know how this close means, but we've been this close for a while. But the reality is, that's that other part of the social responsibility I was mentioning, that we can't be detached from getting that voice to the political side to say, this is an issue, this is a priority. For the most part, ensure that we have a protective health system that protects everything, and not just acting on the disease that shows up today, because it won't be the disease tomorrow. I had West Nile that I had to contend with, smallpox, anthrax, monkeypox. Luckily, I was vaccinated for smallpox, so that meant I was immune to monkeypox, right? MERS, H1N1, the other swine flu, H7N2, Ebola. Ebola was the bane of my existence. My bow tie is Ebola, in case you didn't know. Then Zika. And as I mentioned, we have the other components, right? The cancer, the diabetes, the heart disease. So if you are chasing after each particular incident and not truly coming to things from a prevention model where you're collaboratively approaching and develop systems of defense, systems of surveillance, systems of response, competency training, then you're just chasing after the loudest disease in the room. And that doesn't help anyone.
Yes, in light of the limited resources and also talking about prevention, I was wondering if you could speak to the outreach to K through 12 when kindergartners aren't sexually active or very children. Is that to get to the parents, or is this a long game?
Well, the K through 12 guidance is specific to more so about what to deal with schools and school-age children who may either be addressed as far as negative birth outcomes, those that may have microencephaly, and how what to do with those particular scenarios, how to provide those type of services. Also, the mental health capacity. The child themselves may not be necessarily sexually active, but they may have family who have illness or who has a young child in the home, or the fact that they may also get ill as well. I mean, there's some new information that shows that there's some brain neurological impacts that happen much longer as a period of time from individuals that are exposed. Things just keep changing and keep developing with the science of this particular disease and this virus. So it's not to say sequester it from the perspective of those who are most at risk, but all aspects of risk to ensure that we understand what is necessary from all of our partners to be involved in the Zika kind of response and prevention. Yes, sir.
So it seems like, well, I really appreciate that you brought your practitioner's perspective to the room today in our university setting, and it seems like there's a lot of potential for collaboration with universities to help answer remaining questions about the Zika virus and how it operates and how it transmits, and as well as to provide sort of an advocacy voice, like we were talking about, for additional resources and support. Is that something that's sort of on the forefront of what's going on with NACCHO, or is that?
It's on the forefront, especially in my mind, because one of the things I can tell you that you see me smiling, what I value the most in my public health training was my internship experience. So my school had the requirement when I did my MPH that you had to do 6 credits within your field and 6 credits outside of your field. So I did 6 credit in environmental health and other 6 credit in health administration. And the reality of it is your internship experience provides some degree of direction as to cementing your experience, I should say, your support, your thriving for where you want to be within public health. So it can make you or break you in addition to everything else. There's a great preponderance of positive outcomes from this academic public health enterprise that exists. And we know this by developing academic public health departments, where a school of public health is paired to a public health department. There's synergies around internships, around research, around evaluation, around programs and deployment. There's so much things that you can do by having these particular synergies. And I think it's important from us as a national organization, as we're currently looking to develop internship opportunities, not only from us in the National Association, because we do programs and activities and services, but also to the 2,800 health departments that exist. One of the problems that they find is that not everyone has, let's say, a PhD at a local health department. So, or how, therefore, are you going to provide that kind of guidance and mentorship to someone on the field? So we're trying to look at new innovative ideas of having that kind of a pass-through with senior program analysts or subject matter experts, maybe at the national level, that could help guide that. Enriching the support with the public health institutions, such as schools of public health like this and others, to really get you, the next generation of the workforce, into the workforce more quickly than waiting for you to graduate, in a year, 2 years, 3 years. How to get you that experience, that kind of on-the-ground training that will impact your life for generations to come. And that's where I would say that there's a great opportunity that exists. Some of them have been developed, and it's not only, as I said, as it pertains to Zika, but in any aspect of the work that we do. The concept of moving through this health transformation of the associations of not only the provision of clinical services, but also the public health department as the health strategist, changing the dynamic of how we administer healthcare in this particular country. These are all avenues that you will find you all play a role in, and you all can get in at the ground level, and it helps accentuate you for your careers to come. Hope I answered your question. Yes, ma'am.
You're emphasizing a lot of communication between, maybe lack of communication between the federal government and on the local level and the public health department level. I was just wondering, how emphasized is communication between different health departments in maybe different cities, different states? Is that a really important tool to? That's
an important tool where we sit in the center of as NACCHO. So we have over 50 work groups, and these work groups comprise of local subject matter experts, local health department professionals throughout the country. One of the reasons that I became senior advisor at NACCHO was by virtue of the fact that I spent 9 years as an epidemiologist active on NACCHO work groups. So for 4 years, I was active on the infectious disease prevention control work group. Another couple of years, I chaired the biosurveillance. Another one, I chaired the informatics work group. What that allowed me access to were cities, counties, and folks in Colorado that I probably would not have known about had I not had this opportunity to sit in a collaborative work group setting, working on policies, sharing ideas, sharing what works well, having that kind of support mechanism to say, hey, this is a problem I'm having. What did you guys do? What tools helped you out? I'm using EpiInfo, maybe SATA, SAS. What can I use to make my life and my work better? And that kind of information sharing has been so fantastic that you find, and I'm not just saying that to pat the organization on the back, but the value that NACCHO serves as being that convener, that ability to connect people. I would get questions saying, hey, Oscar, we got this particular issue. Do you know anyone in this area? I may not. Let's get you, the folks in Minnesota. In fact, last week we got an email and a phone call about opioid. And one county needed to get assistance on how to address the opioid and the heroin overdose epidemic that was happening. And I knew that there was some great work being done in Minneapolis, so I got that person from Minneapolis to speak to that health department official. And it works. And we operate in so many different spaces. The public health law capacity, we have a work group of lawyers who help serve public health departments. And getting them involved in issues around smoking, menu labeling, infectious disease, isolation, quarantine, all of these aspects have shown to be helpful when you bring folks together, ideas generate, and you have such a rewarding and enriching experience. So that's why we try our best to ensure that the local health departments are represented and that they have a voice at the table. I can tell you the biggest factor for me personally that verified that was in H1N1. We sat in a room like this and everyone was talking about, well, we need to dedicate monies, and someone raised their hand, won't tell you who that guy is, and said, one of the problems that we see, monies come from the feds to the state and we have no way of getting it directly to the counties. If there's a methodology by which you could have direct pass-through monies to the local health departments, we could do this job much better. And they said, well, we'll take that into consideration. And they were able to do that. So we saw a shift in the way funds were being distributed with the requirement that, okay, you need to take 20% or 10% because you're the state, fine. But you make sure this particular amount goes to the locals. And locals were able to see much more and actualize that in a way. Had it not been for a work group of people talking together and being invited to the table to say, you're representing local health, you're representing us, stick your hands up in the air and say something if you see something. And I would say that has been a benefit. So communication does work with us, and you find we tend to talk a lot.
Okay. Well, Tiffany, come on up. We really appreciate your coming today. We really appreciate Dr. Allen's willingness to come here. You have said, why don't you, we have a token of our appreciation for Dr. Allen from the Dean, and we really appreciate your coming. Thank you all very much.